The topic assigned to me is mediastinal and systemic staging for suspected stage 3 non-small cell lung cancer. I have no conflicts of interest. And under this, I'll discuss under the following headings: why to stage, what to stage, how to stage, when to stage, and specific issues related to stage 3. So the first question is why to stage. The simple answer is because accurate staging implies accurate treatment, and accurate staging in this context also means identifying more potentially resectable cases in which surgical resection can be done, and therefore this curative intent treatment saves lives. And that is why the ISLC lung cancer staging project is ongoing. In fact, I'm proud to share that we are the first site in South Asia to be part of this, and we have just completed the data contribution to the 9th TNM database. Analysis is still awaited and will come out probably sometime this year. And if you look at survival according to stage, you can see that survival depends upon the stage, and stage 1A1 has the best survival and stage 4B the worst survival. And even if you look at stage 3A has the best survival and 3C has the worst survival. That is true whether you talk of clinical stage or pathological stage amongst patients who have undergone surgical resection. And even our own experience is the same, that stage 3A and less has better survival compared to advanced, which is 3B and 4. So the next question is what to stage, and basically we are talking about the staging components. And this is the ISLC TNM staging manual. This is the second edition, and as everybody knows that it has 3 components. One is the tumor component or the local spread, the N component is the regional lymph nodal spread, and the M component is the distant spread. And the combination of the various T and M descriptors form these groups or stagings ranging from stage 1 to stage 4. And treatment decisions are made based upon stage groups, but also taking into account the individual T, N, and M descriptors sometimes. And this is how this is represented, ranging from N0 to N3, from M1A to M1C, and T1A to T4. And as you can see, 1A1 is the earliest stage and 4B is the biggest stage. Specifically for this talk, it is stage 3A if there is any N2 disease, but also if you have any T4 disease with an N0 and N1, or any T3 with an N1. And obviously there has to be M0 for stage 3A. Now, what is locally advanced stage 3? With basically extension of the primary tumor is either T3 or T4 disease, and involvement of the mediastinal and hilar lymph nodes is either N2 or N3 disease. But this is a big spectrum. As you can see, you can have a range from clinically occult N2 disease to discrete lymph nodal involvement to overt mediastinal involvement. And as you go from this left to right, the tumor burden goes on increasing and the performance status goes on reducing. And surgery has a very big role in at the left hand of the spectrum, and the role of surgery goes on diminishing, and palliative intent treatment goes on increasing importance as you go to the right hand side where there is overt mediastinal infiltration. Now there are some practical points to staging. Regarding end staging, a direct extension of a primary tumor into a lymph node is classified as lymph node metastasis. And this is a very common thing I keep explaining to our residents and even otherwise. Sometimes it is said that the tumor is seen, which is very big, but you don't see any lymph nodes separately. Just because you don't see any lymph nodes, it doesn't mean that they are not involved. Similarly, metastasis in any lymph node other than the regional lymph nodes is classified as a distant metastasis. So if you get a cervical lymph node involvement, that is M1B, it is not M3. The other thing is if the primary lesion is resectable, which is T1 to T3, and there is no metastatic disease, one should not assume that the enlarged or FDG-avid lymph nodes or imaging are involved by the tumor, and one must sample them because that can change management. Other thing is if the primary lesion is resectable and there is no N3 disease, which means no contralateral or supraclavicular lymph node involvement, one must try and attempt to get a tissue confirmation if there is a suspected solitary extrathoracic lesion on imaging. because that is going to base it as M1B or 4 and make it unresectable. However, if you sample it and it becomes negative, then the disease becomes potentially resectable. The last point is that if there is bulky mediastinal lymph node involvement leading to features which are typically listed for T staging. For example, there is a recurrent laryngeal nerve palsy and SVC obstruction from a lymph node, not the primary. It remains what is otherwise there, that is N2 or N3 as applicable. The T stage does not become T4. But it has clinical implications of unresectable disease, because typically what is described in the TNM staging charts is that T4 lesion causing SVC obstruction or lesion causing palsy, but there is no description of the nodal disease causing that. So the question number 3 is how to stage. So what is must is all for all cases, whether that is potentially resectable or not. A contrast enhanced CT scan of the thorax, which should include the upper abdomen, basically liver and adrenals. No patient of lung cancer should be or can be treated without having this. And if you get a patient with an X-ray and a malignant pleural effusion, you don't start treatment on that. You have to have this. Now, there are other staging modalities which can be either essential, preferable, or optional depending upon the clinical scenario, and can include a variety of bronchoscopic and associated procedures, and even an upper GI endoscopy, thoracoscopy, which can be medical or surgical and associated procedures, mediastinoscopy, a CT scan or an MRI of the brain, a whole body bone scan, and a PET scan. And if you look among how to stage, basically imaging is of the biggest chunk. Based upon that, you will have patients who will require minimally invasive staging, and amongst them, you will have patients who can undergo surgical staging and ultimately surgery. Now, a PET CT is usually very, very important if a patient is potentially resectable or suspected stage 3, because if you find evidence of abdominal involvement, adrenals or other sites, it becomes straight away stage 4, and the intent changes from being curative to palliative. So a PET CT can exclude metastatic disease except the brain. So it has a very good negative predictive value for nodal disease, approximately 90%, and helps to plan invasive staging, whether it is indicated or not. And therefore, it is recommended in all stage 3 NSCLC patients being planned for a definitive treatment. However, there are problems with PET CT, both understaging and overstaging. Understaging can occur in large central tumor, a proximity of the mass in the node, subcentimetric deposits, and a primary which is not very FDG-avid. That is typical of neuroendocrine tumors. And it can also overstage because of inflammatory conditions and tuberculosis. Now, in a significant proportion of cases, imaging cannot replace invasive staging procedures. Now, this is a depiction of the various types as I was showing earlier. So this is on the D is N0, where there is no apparent nodal involvement. N1 is hilar involvement. N2 is discrete N2 disease, and A is the bulky mass and the nodes. So who needs staging? So obviously in A, where there is invasive conglomerate nodal disease, you don't need. At the most, it may be done as part of a diagnostic procedure. In B, the N2, N3 prevalence is 60%, and yes, you require to stage. Similarly, for C, in which there was an enlarged hilar lymph node, because here also you can have 20 to 25% N2 to N3 prevalence, and here also you need to stage them. In the other case, which was a peripheral tumor, typically less than 3 centimeters, normal hilum and mediastinum, you could omit mediastinal staging and go straight for surgery if the PET is negative. So the next question is, should the N0 or N1 nodes be sampled? So the justification for this is that there is post-surgical unsuspected N2 disease in anywhere from 14 to 37% of unsuspected cases. And in such cases, endosonography can be very useful. It has a very good specificity and a very good negative predictive value, but the sensitivity is lower. And you have multiple options for sampling. The transbronchial needle aspiration, which is basically a bronchoscopic technique, and now most commonly we use the EBUS technique. But you can also go via the upper GI tract, and do the EUS FNA. Again, very good specificity. And cervical mediastomy and VATS is typically reserved for patients in whom the endoscopic procedures are negative. And so this is what is called as medical mediastinoscopy, the combination of EUS and EBUS TBNA. Nowadays, even they are doing with a single scope. Basically, it is called EBUS TBNA and EUS BFNA, which means an endoscopic ultrasound with an echo endoscope guided FNAC. Now, if you look at the comparison, this is a paper by one of my colleagues. You can see that it has very good sensitivity and specificity compared to mediastinoscopy. And therefore, they are preferred as the initial interventional procedure for mediastinal staging. Now, surgical techniques obviously have their role. And as I said, when you have a negative endoscopic staging, but there is still a possibility of nodes being involved, or if there are lymph nodes which cannot be accessed sometimes by an endoscopic technique. And obviously, the mediastinoscopy is preferred, but then you have the older procedures as well. Now, if you have to compare all of these techniques for staging, ranging from the simplest chest CT, PET CT, the endoscopic techniques, mediastinoscopy, and so on, you can see that there is a very wide range of sensitivity and specificity. But for all of these endoscopic techniques and even the surgical techniques, the specificity is very good, which means if you find it, it is there. Finally, when to stage. So it is mandatory or essential as soon as the diagnosis of lung cancer is confirmed. But patients who have undergone neoadjuvant treatment, typically neoadjuvant chemotherapy, and you are planning for potentially resectable early stage NSCLC, you should try and restage once you have completed the initial NACT. Because if you find persistent multi-station N2 disease after that, there is a big debate of whether you should actually go ahead with surgery or just shift to definitive chemoradiation. Now, when you are doing mediastinal restaging after the initial neoadjuvant treatment, a CT scan is needed for all patients. Some people would advocate doing a PET CT. And in selected patients, you may even need to do an endosonographic staging. Surgical confirmation, as I said, is when you are having a very high suspicion of mediastinal nodal involvement and the endoscopic staging is negative. Again, this is one of a paper by one of my colleagues in which they have tried to show that the endoscopic techniques are very useful in restaging with, again, a very good specificity of 99%, but the sensitivity is lower at 67%. I was honored to be part of the co-chair of this expert ASCO panel, which brought out this stage 3 NSCLC management guidelines. These have just been published online in JCO and should get assigned to an issue very soon. And there is a recommendation regarding staging for different types of modalities. So ranging from CT thorax and upper abdomen, which has to be done. A PET CT and an MRI brain again should be done for every suspected stage 3. Endoscopic lymph node staging being the preferred initial modality, and reserving surgical lymph node staging for ones in whom endoscopic staging is negative, but you have a high suspicion. Just a repetition of what I have already told. And these are two very nice flow charts which you have accessed the guideline. You will find that basically suspected stage 3 NSCLC should undergo clinical examination and a CT to rule out metastatic disease, and absence of metastatic disease should be confirmed with a PET CT and brain imaging. And then you have to assess a pathological mediastinal lymph node status, again preferably with endoscopic techniques, and then going for surgical staging if needed. And based upon that, patients would be divided into either unresectable or resectable. And in unresectable, obviously the treatment of choice is going to be concurrent chemoradiation, or for patients who are not fit for that, sequential chemoradiation. You will have a lot of discussion later on in this talk today. And resectable patients will go on to either straight surgery or neoadjuvant treatment followed by surgery. And adjuvant treatment is going to be decided by the pathological staging. And ultimately, just to re-emphasize, it is a multidisciplinary approach, especially true for stage 3 disease, which is the most heterogeneous amongst all stages. And that's why I'd like to end and acknowledge all the people with whom I've been working both for research and clinical practice. Thank you so much.